start with the heart tonight, the human heart. And I'm not a very good artist, so I'm going to do my best to draw this. We have one student, he's an amazing artist. I don't know if you saw Stewie on the board. The other, of course, you weren't coming to draw us. He did Stewie, it was really amazing. I told him I liked Stewie so much, he went and drew Peter. But I didn't care for Peter, so I erased him. Okay, so the human heart. The human heart is about the size of your fist, actually. Kind of shaped like a potato. Blood enters the heart through the superior and inferior vena cava. And I'm also dyslexic, so if you notice I'm turning letters around. Spelling is very much of a challenge for me as someone who's dyslexic. So I interchange letters, I interchange numbers, so please bear with me. Superior vena cava, also known as the cranial vena cava. Inferior vena cava, also known as the caudal vena cava. Cranial caudal, if we do an assessment in nursing, typically we do a head to toe assessment or cranial to caudal. So it's cranial to caudal means head to toe. It suffices to say, if you remember it as superior vena cava and inferior vena cava, you're good to go. These are veins. Okay? Veins going to the heart are carrying deoxygenated blood. Yes, ma'am?
I'm sorry, what is that word vein? Vena cava?
Vena cava.
Yeah.
Vena meaning vein,
Okay.
cava like a conduit. Okay?
What's the word about that?
Inferior. So superior and inferior vena cava. A lot of your medical terminology, if you haven't noticed already, is in Latin, right? So a lot of it's in Latin, and it's helpful to know, you know, root words and things like that. When you start looking at your lab sheets, you'll see that a lot of your labs, you know, are Latin as well. So superior and inferior vena cava, the deoxygenated blood comes into the heart, and both of these are going upward and inward into the right atrium. Okay, so this is the right atrium. So all this venous blood coming from the body is going into the right atrium, or the right atrial cavity. Now, there's a little valve here, which we call the right atrioventricular valve. Or right AV valve. You may also know this as the tricuspid valve. Okay? So the right atrioventricular valve or tricuspid valve, when the blood goes through the right atrium, from there it's going to empty out into the right ventricle. So from the inferior and superior vena cava, both emptied into the right atrium, through the tricuspid valve or the right atrioventricular valve, into the right ventricle. Once inside the right ventricle, there's another valve here. Okay? And it's shaped like a moon, like a half moon, and it opens and closes. This valve right here is called the pulmonary semilunar valve. The pulmonary semilunar valve. Pulmonary is the key word here because pulmonary tells you it's going to go through this pulmonary artery away from the heart. So from the semilunar valve, we see the large pulmonary artery. Okay, so this is a pulmonary artery. We're still dealing with what? Deoxygenated blood, right? We're still dealing with venous blood. It hasn't picked up any O2 yet. So here's our pulmonary artery. pulmonary artery, okay? Pulmonary artery. So where is this blood going? It's going to the lungs. That's where it's headed. It's going to the lungs. So off we go to the lungs, and this looks like big kidneys, but anyways, draw the bronchioles off the bronchial tree, your pulmonary alveoli, where, you know, simple diffusion takes place. CO2 for O2, they look like tiny little grapes. We inhale, air comes in, gas exchange. Okay, so CO2, O2 in, and that O2 oxygenates the capillaries, and all that fresh oxygenated blood is going to come back into the heart via the pulmonary vein. Pulmonary vein. And a lot of times in anatomy and physiology, I know it happened to me too, we're so used to thinking of veins. Veins only carry the oxygenated blood, arteries always carry oxygenated blood. And I had a nurse practitioner student once tell me, you know, if you think about it, veins go to the heart, arteries go away from the heart. I'm thinking, interesting. Because your pulmonary artery is an artery, but it's carrying deoxygenated blood. But your pulmonary vein is carrying freshly oxygenated blood, right? So this has got fresh O2, lots of O2 in the pulmonary vein, okay? And that's going to spill into our left atrium. Now, the left atrium, it's got, the blood now has to go from the left atrium into the left ventricle, but it has to do so going through another valve. So each of these atria have valves. The left atrium has, of course, the left AV valve or the left atrioventricular valve. So here we go. This is our left atrioventricular valve right here. Okay. So the blood has to go through the left atrioventricular valve before it can get into the left ventricle. The left atrioventricular valve is also known as your mitral valve or your bicuspid valve. Why does it have to have so many darn names? It's hard enough to memorize one. Jeez Louise, right? So here we've got the left atrioventricular valve. Now we're in the left ventricle. By the way, the left side of the heart has what type of blood now? Oxygenated. Excellent. Oxygenated blood. Freshly oxygenated blood. Now we're in the left ventricle, and you know what? This blood's got to go somewhere, so we've got another semilunar valve. This time, the semilunar valve is our aortic semilunar valve. Semilunar just means half moon, right? That's all it means. Semilunar just simply means half moon. So the blood's going to go through this aortic semilunar valve, and it's going to go up and outward into what a lot of you are familiar with. Here is the aortic arch, or aorta, the largest artery in the body. And off the offshoots of the aorta, you've got your brachial, your subclavians, your carotids, where everything else is going to go out and feed the body with freshly oxygenated blood. Right? Basic blood flow 101 to the heart. Now, this is by far only scratching the surface. We're just merely scratching the surface, understanding typical blood flow to the heart, and how blood actually flows. There's some interesting things going on, okay? The heart muscle is very interesting because it actually, we know, as part of our autonomic nervous system, part of the central nervous system. The autonomic nervous system is the nervous system where we know that if we go to sleep, our kidneys are still work, our lungs will still work, our heart will still work, right? Even if you pass out in the phlebotomy chair, you're not going to die. You know, you're just going to fall to the ground because your vagus nerve got compressed by some type of hormone due to anxiety and or fear, lowers your blood pressure, not enough oxygen to the brain, boom, down you go. So the autonomic nervous system we're grateful for. The heart beats by sheer virtue of that, and it's almost like a little battery, right? If you see them put EKG leads on someone, and we turn the machine on, and you see those little markings on the EKG strip, wonder, how is that happening? I mean, why? Well, it's electrical. It's electrical activity. And it's been devised for us to be able to look at those little electrical tracings on an EKG cardiac monitor, and we're able to tell all kinds of things about the heart. So I guess we can look at the heart as a type of nervous tissue. It's almost as excitable as brain tissue, which has to be very excitable. Okay, so there are some properties that the heart has that other organs we have do not share. For instance, the heart has several properties that make it very unique. It has the property of what we call automaticity, excitability, permissivity, contractility, and let's see, automaticity, excitability, permissivity, contractility, and there's one other one, and I always miss it. Automaticity, excitability, permissivity, contractility, automaticity, excitability, contractility, excitability, conductivity. Ah. Conductivity. The five characteristics that drive the heart muscle to work. Now, let's take a look at how it really works, okay? The interesting thing about being an engineer and working with materials and working with designs is that you learn to appreciate the beauty of design, and you appreciate how things work at very, very minute nano levels. And the heart muscle is amazing. There are, let's just release some of the stress from the heart for a second. Think about electricity. Electricity, it's everywhere, right? It flows through wires, and we get lights, right? And electricity does all kinds of things. Now your cars have all of this electrical, computerized stuff. If one thing blows, nothing works, right? Electricity can heat our house. It can, turn on our stove. It's amazing. And there's no difference in any electron at the atomic level. They're all electrons. They're very small though, right? Electrons do what? They circle around the atom, don't they? Right? So I'm going to just do a brief, here's the atom. We've got protons, we've got neutrons that have no charge. And then somewhere about the atom, we've got these orbitals of electrons spinning around. And it's this same electron, it's the same electron that goes through the lights, it's the same electron in our heart. Just an electron. No difference. Schrodinger tried to establish the whereabouts of an electron as it was spinning about the atom. So he made up this, we've got this Schrodinger wave equation that Einstein later, worked with. Why was it so important to Schrodinger to be able to know at what point in time we were able to find an electron? Lots of physics behind that. But that's not part of our discussion today. Today, we're going to look at how electrons play a role in the heart and how the heart helps continue to keep us alive while beating. I guess we can start out with looking at the first electron site in the heart. Notice, right as the superior vena cava is coming into the right atrium, we have this tiny little node. It's kind of like a powerhouse, like a breaker switch. It's called the SA node, or the sinoatrial node. The sinoatrial node. It's a node. This is the pacemaker of the heart. And that's actually a test question you'll have next week. What is the pacemaker of the heart? Or what is the SA node called? It's the pacemaker of the heart. The SA node is very important in the sense that the SA node is responsible for beating the heart between 60 and 100 beats per minute, which is considered a normal range. So if your heart's above 100, then you're tachycardic. There's lots of reasons why people's heart beats faster than 100. Can any of you think of some reasons why your heart might be faster than 100? Exercise. Thank you very much. That will do it. What else will make your heart beat fast? Anxiety, fear.
High blood pressure?
Sometimes, okay.
Compensation.
Okay, compensation. Spoken like a true EMT. The acid-base
Anxiety.
equilibrium, what?
They said anxiety already. Anxiety, they said that already.
Anxiety. Oh my God, yes, of course, anxiety. How about medication? You think some medications can make our heart beat faster?
Diet pills.
Thank you. What are some of the medications?
Deep adjustments.
Good, beautiful.
AED medicine.
I love it. Yeah, you guys are right on the ball today.
That's why my chest was racing, because she told me we were having a test today, and I didn't know that. And
I'm
on the way
not,
here, I was rushing.
guess what? I'm not giving you a test.
I know. That's-
So relax. Shh. Hands on the phone. Okay, what else? Epinephrine. Okay, it's a cardiac med. Adrenaline. Well, INE meds. I have some physicians, they argue the point, because I have this one test where I say most INE meds do what? And typically it stimulates the sympathetic nervous system to make everything kind of, dry up and just it's the fight or flight response. It makes your heart beat faster, blood shunts to the kidneys, the lungs, the brain, the heart. But then you've got your INE medications like your atropine, okay, that can control tachycardic fast heart rates. So we go back and forth on that. It's kind of an ambiguous question. So meds, okay, so we looked at meds. What about what you go and buy in a gas station, folks? Cigarettes, okay. Caffeine, yes. And what are the drinks that just stay up for 5 hours?
Mountain Dew.
Okay.
5-hour energy.
5-hour energy.
No.
They say no. They say no.
Sugar, these energy drinks are going to stimulate your sympathetic nervous system quite a bit, and they're going to make you have heart palpitations. Okay. The sinoatrial node does a lot for us. So the sinoatrial node is responsible for beating the heart between 60 and 100 beats per minute. Okay, let's take a look at one of the other nodes, and we're going to look at electron flow. How many of my cardiophlebotomists in here? Just a few. I know most of this, well, no, more than just a few. Okay, well, you are ready to do the IV class that I'm going to teach, which is a class, you're not ready yet, because I know you haven't drawn yet, but when you get to that point, we're going to cover more on telemetry, okay? And we're going to look a little bit at that today, okay? Because you have access to our site to do the actual telemetry course online, my cardio people, so you can actually get another certification, okay, as a telemetry tech. And you can actually take the national telemetry tech once you pass the final on that. It's a take-home final, so don't stress
The
it.
national, can that be done at home too, or?
Yep, the login code we give you gets, I think, an hour to take it.
How much do they start off with telemetry check?
Between 14 and 20, just watching monitor. And by the way, my phlebotomy students, if you ever just want to take the telemetry tech class, you can. It's online. Just go ahead and you can pay for it online. So the sinoatrial node is really important. So what it does, when it depolarizes, typical depolarization is about, well, before it depolarizes, it's usually at a resting potential, like muscle tissue, at about -60 electron volts. When something depolarizes, it goes to around -90 electron volts, and that sets out a chain of reactions and sets out motion. It's kind of like in chemistry, when you did acid-base equilibria and you did salt bridges, or you were able to get energy from the transference of electrons and the movement across the semi-permeable membrane. What we have here is semi-permeable membranes, and we have ions. And some of the best ions that I think is important for all of you to know and remember, is commit to memory, are your ions that participate in your electrolytes. So electrolytes, because they're going to play a large role in lab tests that you're going to be doing. Your electrolytes are potassium, sodium, chloride, and CO2. Those are the four major electrolytes that are important in your body, and they play a huge role in cardiac response and how the heart actually works.
Is that chloride? You said
Chloride.
Potassium, sodium,
Chloride and
chloride.
CO2, yes. The most phenomenal thing is these are the same elements on the periodic table of elements. No difference whatsoever. I believe the molecular weight of potassium, I just off the top of my head, is approximately 38 grams per mole. I could be wrong. Molecular weight of sodium is approximately 22.99 grams per mole. Chloride, geez, I don't know what the molecular weight of chloride is. I want to say possibly might be 34 to 44. 37? I can say 37, thank you. Grams per mole. And CO2 is a molecule, so we're not going to add up the molecular weight, but I can tell you that the CO2 concentration typically is between 30 and 40 CO2 milligrams, possibly per deciliter. CO2 concentration. Chloride concentration is approximately, chloride, I want to say 109, 105 to possibly 109 milligrams per deciliter. And sodium, potassium, 135 to 145 milligrams per deciliter body osmolality concentration. Potassium is 3.5 to 5.5 milligrams per deciliter osmolality concentration in the body. Typically in your body, your typical pH is between 7.35 and 7.45. That's your normal pH in a body system. On the pH scale of 0 to 14, 7.35 to 7.45 is to a bit of the right, so it's a little bit alkaline. But that's a very good buffer region for lots of enzymatic reactions to take place in the body to keep us from burning up to a crisp. There's one other ion that I need to add into this structure of all of these other ions, and that would be calcium. Okay? Calcium in our body is about 9 to 11 milligrams per deciliter. Very important in heart, in the working of the heart. Very important in permeability and what the calcium ion is actually used for with the heart. Okay, too much or too little calcium or hypocalcemia, the person can start going into tremors. They can get very bad arrhythmias that can cause them to die. Okay, a low calcium. When people have low calcium, typically they will get what we call calcium gluconate, and we have to keep them on a monitor while we monitor the infusion of calcium gluconate to get them back up to a calcium level that's within the normal range of 9 to 11 milligrams per deciliter. Okay. So we're going to revisit these sometime today during lecture, but for now I want you to know that they exist and they're very important. And the first four that we talked about are your electrolytes. Okay? So going back to the sinoatrial node, the sinoatrial node transfers electrons through an electron conduit. So the sinoatrial node depolarizes and says, you know what? Hey, like the Fonz, I'm going to send some of my electrons down to my other station, which is called the AV node, which sits not in the right ventricle, but right at the cusp of the right ventricle. So we have this little node right here, and that is called our AV node, or Atrioventricular node. Now the Atrioventricular node is not as tough as the sinoatrial node. The AV node, says, hey, I can do a little bit of work, but I can't handle the power that the SA node can handle. I can only beat the heart between 40 and 60 beats per minute. So it can take over and beat the heart between 40 and 60 beats per minute. Well, 60 is okay, 55 is okay, 51 is okay, 40 is a little bit on the low side. We're really Brady now, bradycardia. We might need some intervention. Okay, we have to transduce our patient if they're in a code situation to try to get their heart rate up a little bit more. Okay, but hey, it's good to have backup. Any kind of backup is good. Think of the AV node as a backup generator. Okay, from the AV node, we're going to go through the right ventricle now. And there is this structure. It's very interesting. It's a very interesting structure, actually. The structure kind of looks, imagine a bunch of fiber optic cables that look like a bale of hay, or a hay bale. And they're all fiber optic cables. Okay, this little structure is called the bundle of His, and basically this is also an electron acceptor. So it accepts electrons on the surface of its little fiber optic cables, and then it shoots them out, shoots the electrons out to other bundle branches that are throughout the heart. So bundle branches are everywhere in the heart. Sometimes people have a bundle branch that shouldn't be where it should be. It's an extra bundle branch. And if it's in and around the sinoatrial node or somewhere in the atria, it's going to cause the heart to beat extra fast and have extra beats. So sometimes they'll go in to do ablation. They'll go in and they'll try to find that extra bundle and burn it. It keeps the person from having those episodes of heart flutter, tachycardia, okay, or atrial tachycardia, because they just happen to have congenitively an extra bundle branch floating around that keeps getting hit by electrons and sending out electrical signals that stimulate the SA node, and everybody's pumping it, too fast. Okay, so we've got the bundle of his. Now, there are some other receptors that have to make sense of all these free-flying electrons. And they're called the Purkinje fibers. Okay? Very important. They may be kind of subdued, but they're very big players. And the Purkinje fibers are all about the heart. And they have a way of transferring all the electrons in a nice even flow and just kind of send them back to the SA node. And I don't, as many times as I've done this, I still have trouble spelling Purkinje, so you guys have your iPhones out. Help me out here. K-E-N-J-I, and it's probably, I got the I and the E mixed up. Maybe it's P-U-R-K-I-N-J-E.
I think it's J-E.
K-I-N-J-E, right? Dyslexia rules. Anyways, check it out on your iPhones, correct my spelling if you will. But the Purkinje fibers, they take all these electrons and say, hey, we've got a job to do. It's a good thing you're beating the heart, but we got to keep this heart going. So they're kind of like crossing guards, and they say, okay, we're going to go back to the SA node, give it a rest, and then we're going to beat it again. And we're going to make it depolarize. So the Purkinje fibers kind of work toward the repolarization and then help the SA node relax and go into depolarization. Now, are you following? You okay so far? All right, let's take a look at something. Any questions? Stop. I'm going to raise the heart. And now what we're going to do is I'm going to draw for you an EKG lead tracing. What is a typical EKG lead tracing? You've seen it online. Maybe you've seen family members, seen it in a hospital, seen it on ER, hospital shows.
What did you say?
An EKG lead tracing. So this is from an electrocardiogram or ECG, electrocardiogram, electrocardiogram, electrocardiogram. This is we're not looking at 12 leads. I just want to keep it kind of simple for you. This is an EKG lead tracing. This all means something. That electrical pathway that I just talked to you about actually translates into what this structure looks like. First thing I'm going to do is label all of the points that you need to know, such as our P, Q, R, S, and T. Those are our waves. Now wait a minute, waves. I talked about electrons and the Schrodinger wave equation. No, we're not going to do anything like that, but electrons and waves. Things you think. Okay, in any case, we have a P wave, we have a Q wave, we have an R wave, well, an S and a T. By themselves, yes, they're important, but what we look at is we look at the distances between the points. So for instance, while the P is important, we look at what we call the PR interval. While the Q is important, we look at what we call the QRS interval. While the S and T is important, we look at the QT interval, and we also look at the ST segment. Kind of interesting. This, to understand what an abnormal lead looks like, you first have to understand what a normal looks like, right? What does a normal EKG lead tracing look like? Well, it kind of looks like this, in the sense that we've got a P, and this P and this P are the same height, so I'm not trying to do a block.
Or negative elevation.
Okay, yeah. So, if I take a look, P, Q, R, S, T, they should look pretty much the same if it's a normal rhythm. In other words, if there's a P wave for each of my QRS waves, then I know the beat is being driven by the SA node. It's an atrial rhythm if there's a P wave for every QRS. Yes, ma'am?
Do you have any idea where in the book this is at?
No, it's on the website. It's on a different website. I'm going to give you the login code too. Okay? It's on the EKG telemetry portion. And I'll
It's
be
on the
giving
what portion?
the EKG telemetry login. You saw the class. I'm going to give you my cardio people a login code to that.
Okay.
So you're very welcome. So I just want you to kind of listen for now. You'll be able to have all of that. And then the day you come in for IV class, I'll be giving you a handout as well. Okay? You're welcome. This is not something that I'm going to require you to study over the week and take a test on next week. This is for the future of my cardiophlebotomy students, so you start getting your feet wet in this field when we do IV class after you've had about 10 draws. Okay? So I'm not going to be testing you guys on this next week. But it's important to know. So if there's a P wave for every QRS, we have an atrial rhythm. We want to be sure too that the distance between all of the P's are the same across the rhythm strip, or basically a 6-second rhythm strip. If we can ascertain with our calipers, which we use to measure the distances between these points, then what we can find is we can find similarities in measurement. So if the P to P intervals are all the same, and the R to R intervals are all the same, so we've got an even ventricular rhythm, and the P to R intervals, P to R. Typically what I do to measure a P to R interval is I do this. I will draw a perpendicular line. I'll drop a perpendicular to the horizontal isoelectric point, which is the horizontal line that this lead tracing sits on. So we call it the isoelectric line. And I'll drop a perpendicular from the apex of the P and the R to the horizontal and measure the distance between the P and R, between the two vertical lines that go through the apices. It's much easier for me to remember it that way than from the end of P or the beginning of P to the beginning of R. It's like, no, I don't think so. It's a little bit, that's too difficult for me. Just drop the darn perpendicular and measure that. If the PR interval is within or less than or equal to 0.20 seconds, yeah, we're doing pretty good. That should be its measurement. Now I'm going to show you how to look at the measurements in a moment. If I measure the QRS, which is from the apex of the Q to the S, it should be pretty much less than or equal to 0.12 seconds. Some hospitals will say 0.10 seconds. A QT interval should be less than or equal to 0.44 seconds. The ST segment, there's not really a measurement for this. Basically what I do is I ask my students to inspect the ST segment or look for what we call ST segment changes. ST segment changes. Delta is the Greek letter for change. So look for changes in the ST segment. If you're doing an EKG on someone and you see this, watch. Let's go ahead and do one more. P, Q, no, PAC, P, Q, R, S. See that? That doesn't look normal. Oh goodness, what in the world is going on there? Well, the little blip that makes it look like it's pregnant up there is called a bundle branch. This is called a bundle branch. B-U-N-D-L-E. But beyond that, there's something much more severe going on here. Notice that the S doesn't come down to the isoelectric point, nor does the T. And the T is pretty elevated. This is called your typical ST elevation MI. Who knows what MI stands for? Please, Todd. Go ahead.
Myocardial infarction.
Myocardial infarction. MI stands for myocardial infarction. So when you take a look at what's going on here, this is an ST segment change. This is your typical ST elevation MI, or in ACLS courses they call them STEMIs. Call 911. Get ready for a possible code. Is it possible to have a heart attack and not even know it? Sure. Who knows signs and symptoms of heart attacks?
Well, different signs.
Please.
Sweating. I'm sorry.
I'm going to turn the air.
Thank you.
You feel sweaty. Anxiety,
Chest pain.
chest pain, constant chest pain.
Sticky, clammy,
Heaviness.
Heaviness.
pressure on the chest.
What is the traditional, what do they say the pressure feels like? An elephant sitting on your chest. Does everybody feel that? No. Sometimes you'll get pain in your left arm. Sometimes you'll get pain in your jaw,
On one side.
one side of the face. Sometimes your teeth will hurt really, really bad.
Sometimes your jaw kind of twitch, or like a,
Like a
Shit.
muscle twitching,
Yeah.
okay? Sometimes you'll feel short of breath, nauseous. You may have diarrhea. You might vomit. Cold, clammy, white, weak. These are all signs and symptoms of a possible ST elevation MI. This can change. This, if you're watching a monitor and you see this, you hit the bat phone now. You hit the bat button. You call the nurses, the doctors, tell them to get down to room such and such. This patient's having a STEMI. They will take the crash cart down there and get ready for a code, okay, because this is very serious. An infarction simply means the heart is being deprived of oxygen in a certain part of the heart. It could be anterior, posterior, lateral. We know more if we're looking at a 12-lead EKG. But if you see this on just a typical, telemetry tracing, this is very serious, okay? And something needs to be done to rescue this patient from going into full cardiac arrest. And if they go into cardiac arrest, what do you think this looks like? What does cardiac arrest mean? Flatline or asystole. Asystole is flatline. Do we shock people if they're in flatline? No.
No. Only-
You know why we shock people if we put those defibrillator pads on them and the defibrillator picks up ventricular fibrillation? Ventricular fibrillation means that they are in a shockable rhythm, and the whole point of shocking them is to stop the heart. Stops the heart. If we stop the heart, who's got to restart it? You guys. If you're doing a code and you put the paddles on someone, not the paddles, but the rhythm pads that pick up and analyze the rhythm, And you say clear, it's got to analyze. And it says, you know, prepare to shock. Shock advised. Stand clear. And the person says, clear, 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 everybody clear. I'm clear, you're clear, we're all clear. Nobody's going to touch the patient. We're all going to stand away. No one's going to touch the table they're on. When that shock shocks the heart, typically what it does is it takes it out of ventricular fibrillation. Because if the heart is fibrillating, it's doing one of these things. It's doing one of these things. No matter how much CPR you're doing, you're not going to build up circulation.
Sorry.
Oh, yeah, excuse me. Oh, yes, they're next door.
They are?
Yes, they
oh,
are.
Great. Thanks.
So the heart's doing one of these numbers. No matter how much CPR you're doing, you're not going to build up circulation through the body. I'm so sorry. I can't talk to you now, Miss Julie. You have to do about 10 minutes of consistent CPR to build up circulation in the body. 10 minutes. That's a lot of CPR. And I've been in a lot of codes, okay, and I can tell you right now, it seems like forever, even 5 cycles. So we shock the heart into flat line, and you're the only one that's going to get it going again. And you got to keep it going. Okay. So a STEMI is probably one of the more important rhythms to recognize when we're talking about rhythm recognition in telemetry. Now, what I'm going to show you, and I'm not going to belabor the subject too much longer since we have much more to do today, is just to give you some of the measurements of how to look at a rhythm strip. When you have a rhythm strip, and you have one of these little boxes, which are so much smaller than this, okay? You almost need a magnifying glass to look at those things. They're so tiny. But one little box has, I am so sorry. Good gracious sakes. I'm just going to put this on. Let's see. Silent. Okay, this little tiny box here. If you take a look, this little tiny box will have 1, 2, 3, 4, 5 little dots. This is what we call our isoelectric line, our horizontal line here. And each of these 5 little dots, the distance between each of them is 0.04 seconds. So if we have 5, 1, 2, 3, oh no, I missed that. Let's do this. 1, 2, 3, 4, 5. 5 of the 0.04 seconds gives us what? 0.20 seconds across the horizontal for one little box. In the vertical, so if we take a look, we have the x-axis, we have the y-axis. Typically on any graph, in any math class, economics class, any class you've ever taken with math or graphs, you'll know the x-axis is usually grid in time. Okay? The x-axis is usually your independent variable. And your y-axis is your dependent variable. And the y-axis, if we take a look and we go 1, 2, 3, 4, 5, well, the y-axis is in 0.1 electron volts. So basically 2 boxes will give us 1 electron volt, right? 1 whole electron volt. And that's, we look at the voltage and we look at the seconds. The voltage is coming from what? The actual beating of the heart. Now let me show you something. And I kind of came up with this because from a math standpoint, I like to try to understand things logically. If you take a look at this P, Q, R, S complex, okay? And let me get another marker here. And I drop another perpendicular line from the apex of the R down to the horizontal. Why can't I draw a straight dotted line? I've just basically split the R in half. The way I interpret when I look at and doing rhythm interpretation is I'll say everything to the left of this perpendicular line is atrial activity.